wonderful presentations this morning. It really sets up a very nice, they tee me off very nice in for what I'm going to talk to you guys about. So let me go ahead and put the presentation up. I had to go back and check the sound because I want to share a short video with you in a minute. So welcome to Addressing Health Disparities and Social Determinants of Health to Achieve Health Equity and Prevention. Before we get started, let me tell you a little bit about who we are. Some of it was covered by Captain Herod a minute ago, but who we are is our PTTC is housed under the National Latino Behavioral Health Association. And it's a nonprofit organization located in New Mexico. Our executive director is Mr. Fred Sandoval. The priorities for NALBA include targeted capacity expansion for services for Latinos, Latino behavioral health evidence-based practice, and I'll share with you in a minute some work we're doing there, some legislative work, some funding, focus on the opioid crisis and suicide prevention. Now allow me to introduce our Technology Transfer Center. The Hispanic Latino Technology Transfer Center is part of the TTC network. It was mentioned already, it's a multidisciplinary resource for all of you, for professionals in the prevention field. It was established by SAMHSA and is comprised of 10 domestic regional centers. Our center is focused on Hispanic Latino communities and the workforce that is serving those communities. I serve as the project director for our PTTC, and I'm joined by Dolca Michelle Celaya, who's our coordinator, and Priscilla Giamazzi, who is our executive administrative assistant. As it was mentioned earlier, Texas falls under the region. Each state belongs to a regional PTTC. Texas belongs to the Southwest PTTC. And the director is Marie Cox, and you can see the contact information on the screen. They provide training, technical assistance. They work with the needs in the prevention field in your region, and they tailor to the recipients in the prevention field, and they're based on prevention science. And I'm sure they would love to hear from you.
Yeah, probably.
Someone has their mic open. If you can please mute, thank you. They have a webinar coming up, and they would very much like to invite you to participate. Quantitative on December 8th and qualitative on January 26th. So let's begin. You know, I have an ambitious learning objective, but I really hope that we can walk out of here and you can get a better sense of what we're trying to do in this field. So hopefully we'll get to define health equity, disparities, and literacy, how culture and cultural competence affects services, some barriers, and a framework that maybe some of you are utilizing or some of you can utilize. And again, it's going to be an overview because of our limited time, but I think I have enough for you to be able to move with it. I want to start also with my favorite quote. If you talk to a man in a language he understands, that goes to his head. If you talk to him in his language, that goes to his heart. And that was attributed to Nelson Mandela. And then I want to show you this brief video to kind of get us going. So I like to start presentations like this with that video, kind of to ground us a little bit and get us out of ourselves and understanding, what a small role we really play in this global world. Because no matter where we are exposed to many of these cultures, religions, languages that play a role and show up in our communities. So how can we address these issues? Cultural competent behavioral health systems, those that provide cultural and linguistically appropriate services, have the potential to reduce those racial, ethnic health disparities that exist. Because when the clients don't understand what you're trying to tell them, where they cannot grasp how to be able to help their children make the decisions that we're encouraging them to make, the healthy decisions that they're encouraging them to make, it makes it really difficult for them to be able to be supportive. So I wanted to start by having a poll question. And a poll question is going to pop up in the screen for you to be able to answer. So when discussing health equity and equality, blank only works if everyone starts from the same place. I think everyone has answered. Thank you. So the majority of you shared equality. So equality implies sameness. It promotes sameness and justice by giving everyone the same thing. It only works if everyone starts from the same place. So most of you were right, and I appreciate that. What this means is when you look at the screen, you look at the graphic that I have up there right now, everyone got a box, but not everyone could reach the apple. So equality is about sameness to the left. Everyone got a box, but not everyone is starting from the same place. Equity is about fairness. It makes sure that people get access to the same opportunities. That's all that it means, is getting access to those same opportunities. Sometimes our history, our current circumstances, policies, barriers to participation. We must first ensure equity before we can enjoy equality. So what often happens is in some of our programs, we believe that what's working or the way we've been doing things for a long time should continue to work. But what happens is our community changes. Where your office is located today, well, most of our offices in our living room these days, but before March, where your office was located, that neighborhood changes. There is a progression of how neighborhoods get their own culture. They develop their own environment. So we need to be able to be adaptable to that. So if we have equity and equality, when we talk about equity, if we give everyone that opportunity, so equity would be the attainment of the highest level of health for all people. So everyone deserves that fair chance to lead a healthy life. No one should be denied the chance because of who they are, if they grew up with resources, rich, poor, where they live, what kind of technology they have. Nobody should be denied a fair chance to lead a healthy life. And if that is what equity gives us, then what is a health inequity? So the health inequity is the difference in health that are avoidable unfair, and unjust. And I want you to focus on those three words: avoidable, unfair, and unjust. So health inequities that are affected by social, economic, and environmental conditions. Social inequities, for example, when a person or a group is treated unfairly because of their race, their gender, their class, their sexual orientation, or immigrant status even. So those are some avoidable, unfair, or unjust. And then economic inequities occur when institutions like governments, houses of worship, schools use their authority to create an unfair disadvantage. So those are economic. And environmental inequities means that where you live determines what kind of opportunities are you going to have. I live in Georgia, and we have, just like Texas, very rural areas. And I've visited every county in this state. And in some areas, you can clearly see it. Just driving to wherever you're going, you see the old factories that closed, the stores that, and this was before COVID. So depending where you live dictates what kind of opportunities you're going to have. And then if we do that, we have to then discuss what is a disparity, because we continue to hear these words of health disparities. And a health disparity is the difference in health outcomes among groups of people. And unfortunately, we have disparities in every single area of health. Now, most of them we hear is health disparities in general physical health. We hear about cardiac or cancer, but we also have it in behavioral health, and we have it in prevention. So these are disparities that are affected by the inequities and health behaviors. Now, health behaviors are influenced by those inequities. Things like smoking or poor nutrition and lack of exercise. Those are behaviors that people participate in sometimes because of those inequities, and they lead to poor health. And then we're trying to avoid people beginning their use of tobacco, alcohol, and other drugs. And we need to take into account the inequities that they're living with. So, those concepts of equity and disparity, they're inseparable. When you implement them, there's policies and practices that really want to aim to promote the goal of health equity, but they don't always eliminate the disparities. So they have to work hand in hand, and we have to be able to set a foundation for that. And then when we talk about what causes a health disparity, one of the big ones is the inequities in the social determinants of health. And we hear a lot about the social determinants of health, but sometimes we really don't know what that is. And they include, things like, do we have the resources just to meet our daily needs? Do we have safe housing? Do we have local food markets? Can we get fresh fruit and vegetables? Do we have access to education, economic opportunities, even jobs, healthcare services, transportation, and that's a big one, public safety, for some instances, language and language literacy, and this includes American Sign Language. We have 500,000 people in the state of Georgia who are deaf or hard of hearing. And there are very few prevention services that really address that. So we need to make sure that we address a health disparity. And then I also wanted to present to you with health literacy, which is another one of those definitions that sometimes we fail to take into account. So, we go on our everyday and we teach people some of the wonderful programs that we have available to us. And we have wonderful staff that are delivering those programs. But sometimes we have to take a step back, and we need to make sure that people have the capacity to obtain, process, and understand the information we're trying to give them. Because otherwise, yes, we will deliver the message, but when they get home, they won't be able to implement it because they didn't obtain, process, or understand what we were trying to teach them. So we want to make sure that we also address health literacy to the individuals that we're providing services, and that they understand the prevention information that we're trying to give them. This can be difficult with adults in sometimes, because there is adult literacy issues that we still have to face. So there may be issues with the individual even being able to read if we're giving them some written materials. So we have to take that into account. We also want to address cultural literacy. So, when you talk about cultural literacy, is the ability to converse fluently in the idioms, allusions, and informal content that creates and constitutes a dominant culture from being familiar with the delivery of services. And this can include like specific words that we may use to refer to places or to each other. But this may also be geographic. It may be understanding where you come from. If you come from another state, or if you come from a certain neighborhood, is making sure that we understand what that means. If there is slang that's being used, literacy demands interactions with the culture and reflection of it. This literacy stresses the knowledge of places of information, and is one of the biggest icebreakers in order to engage individuals to participate in our programs. And it can be positive or negative. Not having cultural literacy can create some negative consequences. I often use the example of a physician that enters into an examination room where there is a young woman, and the physician is thrilled. He's so happy. He tells this young woman that she's pregnant. Now, unbeknownst to this doctor, he's placed her at risk, because in Ethiopian culture, the fact that you are pregnant and not married brings a lot of shame to your family. And many women end up attempting suicide because of that. This physician thought he was giving her wonderful news that she was going to bring a life into the world. And unbeknownst to the physician, he put this patient's health at risk. So we need to make sure that we have those aspects of what we're trying to do. If we don't address health and cultural literacy, we are going to be unable to serve those most in need, those that really have a reality that makes it almost impossible to dig themselves out of it. So we need to make that effort to address those issues. I added a few slides on workforce development that I'm going to move through it pretty quickly. One of the things that we have to be able to address issues of ethnic and cultural sensitivity and competency. At the Hispanic Latino PTTC, we're trying to develop bilingual prevention specialists. Everything we do in our TTC is in English, Spanish, and Portuguese. Every webinar that we do, we re-record in that other language. So it's an original delivery. All the slides are translated and adapted. And you can find all that in our PTTC page, but you can receive it in your own language, in the language that you prefer. And we need to continue to develop bilingual and bicultural prevention specialists to make sure that they can meet the demand of those communities that are showing up in our service areas. And when we do develop them, there is one key role. We also have to support them the same way that we support every certified prevention specialist. That means we have to give them culturally and linguistically appropriate tools for recruitment, retention, supervision, and other supports. How does culture affect an intervention? So to understand, we have to be able to know whether or not they can access prevention services, whether or not these individuals have family and community support, and what is their willingness to seek services. Minorities and immigrants, refugees, they share a lot of factors and that play a role in understanding prevention needs. Prevention is not necessarily a well-known field outside of westernized countries. And we have to be able to make sure that our programs are staying free from racism, discrimination, and that is addressing issues of economic impoverishment. If we want them to trust us to be able to come in and take care of our services, we need to be able to understand the cultural and social influences that drive them to seek those services. Some of the things that helps us understand that is by learning how do these members communicate? How do they tell us when they're in crisis, or how do they view a crisis? How do they interpret the meaning of a crisis? Even with our current state in COVID, we're seeing communities that are responding better than others. And we're seeing communities that are not responding to what's being recommended. So we have to make sure that we address that. So briefly, a couple of barriers, and then I want to share some solutions for you. So systems and providers don't set out to make it difficult for minorities and others to access behavioral health services, to access prevention services. Sometimes the best intentions don't yield the best results. Language is often a primary barrier to many people in accessing services. And we wanted to at least touch on a couple of areas that talks about language. One of the barriers is expressions of culture in healthcare. And this has to do with how the individuals that are coming into our centers express themselves and what their beliefs are. How do they view health? How do they view prevention? Some of them believe in supernatural causes and won't be able to follow what we're trying to teach them, but we have to take that into account. And then there is barriers at the individual, provider, and system level. At the individual level, they're related to the individual's characteristics, like demographic variables, social structure variables, health beliefs and attitudes, enabling resources, community resources, and how they view what we're trying to provide. It's that individual level. At the provider level, we really need to talk about who we are. What are our skills and our attitudes to work with individuals that are different than we are, or that have different beliefs, or speak a different language, or eat a different food, or dress differently? What are our attitudes towards working with individuals who have accents, for example, that sometimes may be difficult to understand? And then at the system level, it's one of the biggest one, because this, to address disparities, equities, inequities, it has to come from the top. It has to come from the highest levels. The support has to come from the highest levels. So how do we do that? So some of the solutions include policy solutions. There's always solutions that address funding mechanisms. At the state level, in some places, you can find a cultural and linguistic competence office There is the national class standards that are recommended for organizations, even for state systems. Um, Telecounseling, many of our programs had to go into a virtual mode, and we need to be able to address those and make sure that our providers can do that. At the facility level, I do a lot of training for facilities on how to investigate where they are, what is their baseline for cultural and linguistic competence. And we look at things as what is the makeup of your staff? What is the makeup of your board of directors? Do they reflect the population you're serving? Do they reflect the community where you are located? And it's real easy for us that the census provides a lot of information as to who is living in our zip code. So if we know that there is a large number of individuals who are not accessing us, then we need to ask why, and how can we provide, how can we give them the same opportunity to have a healthy life. And provider solutions, the staff training, make sure that we have the right staff. One of the greatest things I ever did for my prevention staff is I would offer them mental health first aid. And I know that it was a prevention program, but the mental health first aid training really makes an individual have to question and have to open up their mind in a different way to truly understand who's going to be walking through the door and to recognize other issues that may be going on. Finally, I want to share with you, what makes a culturally competent agency. So, these agencies view minority groups as distinct and having different subgroups. We don't just put everyone under one label. They spend a lot of time making good hires of individuals who can be unbiased. They consult with those communities, minority communities in their service areas. That's how we learn. My prevention program I ran for 15 years, and every day I learned something new from the community. Again, it's a fluid community. And then they provide the support for the staff. It's not just a 2-hour training once a year on cultural competence. These are active things that we can celebrate throughout the whole year. Supporting policies that enhance services to diverse clients, and making sure that the staff, the frontline folks, can come up to you and give you suggestions of what they're seeing. There's nothing more frustrating than having the frontline folks, trained, competent, unbiased, and they know what needs to be done, and they bring it up the chain of command to get shut down because the people above them may not understand what they're trying to do. I know my time is up, so I want to say thank you so much for everything for giving me this wonderful opportunity. I love Texas. I have great family and friends in Texas. I know there's going to be a question and answer period, but before we go, you'll get a copy of some of these slides, and there is an evaluation. Any of you that have federal grants, we have to collect this. If you place your phone camera on the QR code, it should open up the link for you to be able to do that. And then I believe Audrey is going to put the other link in the chat box so you can access it that way. And with that, I'm going to turn it back over to you and see if there is any questions or time for questions. Thank you so much.